Hello, everybody. Welcome to That Expert Show, where you help run the show. I'm Anna Canzano, and we are discussing heart health today, heart attacks. We're calling it Heart Attacks 101 because this is a topic that is near and dear to many of us. I've had family members who have fallen victim to heart disease. I have a cousin who is currently in a vegetative state right now because a couple of years ago he suffered a heart attack at work. Only in his 40s, a father of four, and his life is just interrupted right now, along with the rest of his family as they wait to see if he will come out of this. So I would think that somebody in your life in some way has been touched by cardiovascular disease, whether it's yourself, whether it's a family member or a friend. I would ask you to consider sharing this broadcast right now. Who knows? You could help save a life. You could share it onto your Facebook page if you're watching it live, or just give us a retweet. You don't know who might see it and who might benefit from the information that we're about to share. Very excited and very honored that Reflex Knee Clinic is a sponsor of this show today. These are the folks who are the experts in knee pain. Stick around and I'll share with you a personal story about Reflex Knee Clinic and how they have made a huge difference in our life. Our guest today is a preventive cardiologist, a member of the American Heart Association, and in fact was recognized by the organization as their cardiac care provider of the year. He is the only cardiologist who has been board certified in all of the following: cardiology and internal medicine, echocardiography, nuclear cardiology, clinical lipidology, cardiovascular computed tomography, and he's also a specialist in clinical hypertension. Yes, I just managed to say all of that. He has taught at Jefferson Medical College, the University of Texas, as well as Harvard Medical School, and he joins us live from Dallas, Texas today, Dr. John Osborne. Dr. Osborne, thanks for being with us. I'd love to dive right in and just find out from you initially, what led you to go into the field of cardiology? Was it a personal motivation?
So I have heart disease that runs in my family. And as it turns out, later in my career, my brother, who had diabetes and had some lifestyle issues and had some weight issues, ended up both needing a kidney transplant as well as bypass surgery.
Wow.
He now, in the meantime, we've gotten all of those factors under control. He's lost about 120 pounds. His diabetes has gone away. His blood pressure is normal. His cholesterol levels are great. He doesn't smoke anymore. And he's a testament to what can be done to help prevent cardiovascular events.
Well, and that is something that we were talking about as well, is the impact that your lifestyle can have. You know, this is one of those issues, one of those diseases that we may not seem to talk about as much in the media, but the fact remains cardiovascular disease is still the #1 killer of men and women in America. 40% of all deaths, you were saying, are because of cardiovascular disease.
Exactly. That's about 1 every 38 seconds. Now, when I started in cardiology, it was 1 every 30 seconds. So we're getting better, but still the numbers are still remain staggering.
And how do the other causes of death compare to cardiovascular disease? If it's the #1 killer, where does it rank in terms of the other causes?
So if you look at strokes and heart attacks, cardiovascular deaths due to strokes and heart attacks, that those deaths are greater than the next 7 causes of death combined, including cancer and heart disease and motor vehicle accidents and all of those other things that can get us.
That is really startling. And now you're saying that improvements have been made as far as heart attacks and cardiovascular disease, but there is still so much work to be done.
I'm delighted to say over the last 20 years that we've lowered the risk of cardiovascular death by about 30%, which is fantastic news. Having said that, still 40% of us die of cardiovascular events. And to make that matter worse, not only is that number still extremely high, but as far as the manifestation, the first symptom of cardiovascular disease in half of men, only 2/3 women, is you die.
Yeah, so there's really not a lot of warning signs when it comes to these kind of attacks. And really, we attribute heart attacks to older folks, but these kind of events can take young people. We were just talking about the 20-year-old pageant winner who passed away this week because of a heart attack. We've had close family friends with student athletes in high school who have passed away because they had an underlying cardiac issue that they didn't even know about. I wanted to lead off with a question from somebody on Facebook. Heather had a great question, and it does apply to women. She says she feels like there's a ton that she needs to know, but that she just simply doesn't know. What are the most commonly overlooked heart attack symptoms in women? What can we look for?
Yeah, we know from a lot of research that women and their symptoms of heart attacks can be quite different from men and making it more difficult to diagnose. Those symptoms could be just nausea, can be fatigue. So who has not had nausea or fatigue? Can be back pain, shortness of breath. So the classical, what I like to call the Hollywood heart attack, elephant sitting on my chest, radiation of the pain down the left arm, up my neck, those kind of symptoms certainly do occur in women, but probably only in about a third of women are those the predominant symptoms. More typically, the symptoms are non-specific. That is, again, shortness of breath, fatigue, nausea, back pain. So that makes it more difficult for women to seek medical attention.
Interesting. So then if those are such nebulous symptoms that, I mean, if you're listing those off, I would be prone to ignore every single one of those and just write them off as being, a tired mom of toddlers. What would be the sign? Like, what would be the thing that you would have me pick up the phone and call the doctor about?
I think part of it is also understanding risk factors. So risk factors include smoking, of course, or tobacco use, I want to say overall, diabetes, high blood pressure, high cholesterol. Family history is critical too, because there are a lot of genetic components to this condition as well. So the more that sounds like you and that the more of those risk factors you have, the more that we need to be proactive about trying to understand what's happening with you.
I think there are blood tests too that can be indicators. I know that after having 2 kids, my triglycerides, which had never been a problem, shot up to ridiculous numbers, and I couldn't figure it out. I was trying to manage it with diet and exercise and all the lifestyle things, but eventually my doctor just said, you've tried for half a year to a year, and the numbers still aren't going down, and we've got to put you on medication for that.
Mm-hmm. So absolutely, and what's interesting about women, and we've looked at this in pregnant women, is that cholesterol levels clearly go up in addition to triglyceride levels as well. So you certainly manifested that, but there's probably also, I suspect, an underlying genetic predisposition, I would bet, or as I like to tell my patients, I'm sorry, but you chose the wrong ancestor.
Right, because we had so much control over that. Yes, that was what my doctor had concluded, was this is clearly something genetic that is potentially not within your control if you're doing everything you can. Something interesting that we spoke about just prior to the show starting was the effectiveness, the efficacy of medications. Like pharmaceuticals are developing such effective medications for cholesterol, triglycerides, you name it. So is there an effect on people who have been diagnosed with some kind of cardiovascular disease, but when they go to make that choice of what to eat or how to live, they are rationalizing their bad behavior because of the medication they're taking and it's available to them?
Sure, it's I take this drug, therefore I can. So that, unfortunately, we've studied that, and it does exist. Again, I think we always have to keep reminding people medications many times are going to be extremely important, and the right medications and the right patients, but also this is based on a foundation. I always like to think of this as a pyramid. The foundation of that pyramid is lifestyle changes and choices, eating the right diet, exercising regularly, not using tobacco. Those are really the foundation of preventative cardiology, but also just preventative medicine, period.
And you're saying, you're talking about exercise. We know that exercise and activity are both essential for heart health. But interestingly, we know that knee pain is the #1 cause of disability. So if you can't exercise well, you're actually increasing your risk of developing heart problems. that's why I wanted to let our viewers know, if you are in knee pain, you've got to talk to the experts at Reflex Knee Clinic. These folks helped my husband, John. He had severe knee pain just from running, exercise, or basic activity. And he was really headed to a double knee replacement until he talked to the folks at Reflex Knee Clinic. They gave him stem cell treatment. They gave him platelet-rich plasma treatment, PRP. And I have to tell you, it's been life-changing. So if you are in knee pain or you know somebody who is in knee pain, go to reflexknees.com. You can read about his case study, you can read other patient testimonials, and you can get back to life. Really encourage you to talk to the folks there. And, you know, how often, Dr. Osborne, when people come to you, when you get a new patient that comes in, are they experiencing some kind of disability that has prevented them, or at least dissuaded them from fully exercising and living that lifestyle?
Oh, absolutely. I think you hit the nail on the head. This is the knee pain to chest pain continuum. I can't tell you how many patients I've seen who are doing pretty well, exercising, doing all the right stuff, physically, and then develop some kind of orthopedic problem, low back pain, knee pain, joint pain, plantar fasciitis, something that really prevents them from doing that regular exercise and activity. And it can have a dramatic impact upon blood pressure, weight gain, increased blood sugar, diabetes, all of those parameters. So it is so critical that we have to treat people holistically, and that if we need to address the things that can prevent us from doing regular exercise as well. And that's critical.
It's interesting because a couple of the questions that have been posted from viewers on social media have to do with their interactions at the doctor's office. For example, Kylan on Instagram wants to know, what prevention steps can we take at the doctor's office as patients before heart issues arrive? Any testing or topics to address with the doctor?
Oh, absolutely. Again, I think it's one of the things I think it's very important is think about your family history, and you really need to share that with the doctor. And sometimes you have to go back and talk to members of your family, mom, dad, maybe aunts, uncles, whatever. Sometimes there's a lot of heart disease and vascular disease that runs in family that we may well not be well aware of. I see people all the time and say, oh yeah, now that I think of it, yeah, dad was 72 and just killed over dead. And it was just, they sort of take it as, yeah, it just happened.
Right.
So I think knowing and being aware of family history is very, very important. But please discuss these issues and concerns with your doctor. There's a real revolution, too, in other tools to be able to diagnose early heart disease long before you have symptoms. In fact, new guidelines just came out at the American Heart Association meetings this last November in 2018 that introduced some new tools and decision-based tools to identify and understand patients' risk. One of these tools is what's called a coronary artery calcium score. It basically, I like to think of it as the cardiac colonoscopy. It allows us to find the polyps long before you develop the cancer, and can be also a useful adjunct to having a discussion with your doctor about how to understand your risk and mitigate and manage those risks.
So is that an assessment that the doctor would offer to just about anybody, or what is the process by which you would attend that test?
So if you are asymptomatic, you don't have diabetes, haven't had heart disease, you don't have genetically high cholesterol, your doctor should do an ASCVD, or atherosclerotic cardiovascular disease, risk score that takes into account the things we talked about. And if your risk of an event over the next 10 years from that calculator is in the 7.5 to 20% range, it's recommended that you can consider doing and obtaining one of these coronary artery calcium scores. It's done with a CAT scanner, takes a few minutes, there's no prep, IV, fasting, etc. Pretty slick. Depending upon where you live, can be pretty inexpensive, generally less than $100. But it really provides a really whole nother level of information about early, as we call it, preclinical atherosclerosis, or the early plaque, the early stuff, long before you get blockages and start having symptoms.
That's interesting. I would be curious to know if most insurance companies would cover that if you were asymptomatic.
Alas, no. But it's pretty inexpensive, and I think now that it was just recently endorsed as one of the strategies in patients who have not yet had an event by the American Heart Association, I think that we're going to see that change.
Interesting. Yeah, I would assume so, because the cost of treating somebody's cardiovascular disease over a lifetime is far more than $100 for that test. Just for our viewers at home, I will be taking notes, basically giving a Cliff Notes version of this interview. I know Dr. Osborne's talking a lot about a lot of terms that you may not be jotting down as you're watching. So as always, after each episode, I create a tip sheet based on the key points that our expert has covered within the course of the interview. Cindy on Facebook has a question about when a heart attack happens. She wants to know, what can we do to advocate for ourselves so that we get the best possible treatment? She says, as an older person who is also overweight, she does not want to feel like she is not as important or expendable, for example, compared to someone else.
Yeah. Well, and unfortunately, there still are lots of remaining disparities amongst different populations and men and women, both as far as appreciating heart attack risk, treating heart attacks, and of course, racial minorities, et cetera. So I think you always have to advocate for yourself. I think just don't take no. If you're concerned it's a heart issue, don't take no for an answer, because it is extremely common. And again, estimates are that up to 80% of these cardiovascular events are ultimately likely preventable.
What would you say would be the most surprising information for people in terms of who is at risk? I think, like we discussed, when you think about a heart attack, you generally think about an older male. What information do you have that would be surprising to people in terms of the person who is at risk for a cardiovascular attack?
Well, I'll cite one of my favorite statistics, and I want to preface this by saying I want to stress that I'm not saying my disease, the things that I specialize in, is more important than others, right? Ultimately, we want everybody to lead a very long, happy, successful, healthy life. Having said that, if you look at cardiovascular disease versus breast cancer, 10 times more women die of cardiovascular disease than breast cancer every year.
Wow.
In fact, of the women with diagnosed breast cancer, those women are more likely to die of heart disease after being diagnosed with breast cancer than they are the actual breast cancer itself.
Wow, that is stunning. And I guess that would surprise me in terms of the amount of coverage and just the amount of media time that we spend talking about breast cancer. They've certainly done an ample job of getting the word out about the risks of breast cancer, but that is good to know. We have some questions about heart or high blood pressure, rather. Mitch and Ginny on Facebook both want to know about high blood pressure. Mitch says it seems to be an indicator of possible heart attack, but besides exercise and daily aspirin, what else can I do to avoid high blood pressure? Ginny says she wants to know how best to control high blood pressure. Sounds like she's already in that category and she's never had it before now.
So fantastic question. So if you look at high blood pressure is actually probably the most common cardiovascular disease, period. In fact, more people, the main reason people go to see their doctor in the U.S. Is for the diagnosis, treatment, and management of high blood pressure. So it's incredibly common, only occurs in about 1 out of 3 adults. That's about 80 million people in the U.S. So it's incredibly common, and it is also another major risk factor for heart disease. As far as management of high blood pressure, I'll focus, of course, on the lifestyle part of that first, which is going to be the plan A for everybody, is maintain height-weight proportionality, avoid sodium. In fact, new guidelines came out for sodium restriction, saying that everybody should be below 2,300 milligrams of sodium a day. And if you have high blood pressure, probably below 1,500 milligrams. To give you an idea, in the U.S., we get about 7,000 or 6,000 milligrams a day of sodium in our diet. Most of that already in the food that we eat, by the way, particularly processed things we don't make. So watching your salt intake, again, regular exercise, of course, avoiding tobacco, trying to stay height weight proportionate. But if these things are not working, please see your doctor to have that evaluated. And there's over 150 different medications for high blood pressure. So if you need medication, despite the plan A of diet, exercise, weight loss, et cetera, then there's almost no one that we can't well control their blood pressure and help to dramatically lower their risk of cardiovascular events.
So many options there on what to take. James on Twitter wants to know whether you've ever had a customer, I think the answer is going to be yes, with cardiovascular disease that you have cured, or is there a cure?
So, as I said before, we estimate up to 80% of cardiovascular events can be prevented. Having said that, I've had patients in my practice now, I've been in practice 22 years, who had an event, who had bypass surgery a number of years ago, up to over 20 years now, who, as we've worked with them and pointed them in the right direction, got them the right medications, have never had another cardiovascular event, and that's much more the rule than the exception these days. And I have to tell you, I was just this weekend at one of my patients' birthdays. He just turned 102 years old, and I've been taking care of him for about 20 years, and
Wow.
He's doing great.
I would say you've done well with him, 102. Tina is watching us live on Facebook right now. Tina, thanks for tuning in. She says that one of her friends just had 3 small strokes. Fortunately, she recovered almost 100%, no high blood pressure, no high cholesterol, but there was family history. For prevention, the doctor put her on statins, which she is not tolerating very well. Is there an alternative to statins? Otherwise, she's very active and eats healthy. What else can she do for prevention? She is in her late 40s.
One would be blood thinning medications like aspirin. There are other anticoagulation or blood thinning medications that could be very effective depending upon the patient and what caused the stroke. The other general class is going after cholesterol. Lots and lots of data that cholesterol drugs, the statins, do help to lower the risk of stroke. All I can say is that work with your doctor. It may be the first statin they used at that dose may not be agreeing with you, but there's a lot of other options, a lot of other drugs in that class. The fact you have side effects with one doesn't predict you'll have it with another. It may take a little bit of time to figure that out, but most of the time we can find a strategy that we can use to get these patients on the appropriate medical therapy and be well tolerated.
Is there a downside to statins?
My pat answer is the downside of statins is that if you take them, you're going to live longer and have less strokes and heart attacks. That's the main downside of statins. All drugs have side effects. Statins are certainly not immune from that. Most of the side effects, though, tend to be annoying, muscle aches, joint aches, that we can mitigate. We can use lower doses. We can do every other day dosing. There's a lot of tricks up our sleeve that we can work with our patients to do. But the side effects, again, mostly annoying. Rarely are they medically serious, but the statin class of medications, and there's lots of stuff on the internet about these, of course, good, bad, and ugly. I will tell you that they are the most exhaustively studied class of drugs in the history of humanity. No more studies have been done with any other drug except for the drugs statins. So we understand the upsides and downsides, and they certainly are really incredibly useful tools in our armamentarium to further lower the risk of strokes and heart attacks.
Armamentarium, that is an SAT word right there. I love how Dr. Osborne just throws a word out like that, like it's in everybody's normal vernacular. Definitely mine, yeah. I would love to, before you go, address individual demographics. So we've talked about women. We can talk about men, but I also would love to address different ethnicities and the risks of heart disease and how they might differ between ethnicities, because there is some statistical evidence of that.
Oh, absolutely. This is not a level killing field. So particularly if you look at some ethnicities that are particularly affected by cardiovascular disease, non-Hispanic African Americans really have an incredibly disproportionate burden of cardiovascular disease and high blood pressure. Of course, Hispanics are right behind that. And then also the other population, particularly in the U.S., are South Asians. So South Asians really have an incredibly high burden of cardiovascular disease. So individuals who hail from Bangladesh, India, Pakistan, those countries really have an increased burden of cardiovascular disease versus everybody else. So this is the burden of disease is not shared equally, but particularly South Asians, African Americans, Hispanic individuals really have an even higher risk of cardiovascular disease and need to be that much more careful.
And do we know why this is the case? Does it have to do with diet or environment or just purely genetics?
Yeah, I think it's all of those things. If you look at South Asians as an example, very high rates of metabolic syndrome and diabetes, particularly when they become westernized and start eating a Western and acting a Western type with Western occupations and sitting behind computers and eating fast food and such. And then African Americans, again, are very much more sodium sensitive. That is, are more salt responsive as far as their effect on high blood pressure, et cetera. So there are lifestyle issues that are just incumbent upon living in the 21st century, but also genetics clearly play a role here too. But all of these things can be identified and help to, and we can reduce that risk.
Right, absolutely. The other demographic that I wanted to address were student athletes. We have good friends who had a son, just a star basketball player who was playing for a high school here in Oregon, and he had an underlying heart issue that was never detected, played a game and passed away that evening, and it was just such a shock to everyone in their family and in the community. His mom was a nurse even, and they've gone on and done amazing things. They've established an organization that actually does cardiac screenings for student athletes. They also have raised the money to put defibrillators in high schools throughout the Pacific Northwest. But what advice would you have for the parents of student athletes for the silent killer that might be in their chest?
Yeah, death from this disease is always tragic. Sudden death is probably even more so, and particularly in these young people that we've been talking about. All I can tell you is that be aware of family history again, and there are tools and mechanisms to screen for these conditions. We don't know what the best tool is. We're still working on that to figure out what the best strategy is for these young athletes, et cetera. But if you have concerns, I certainly do encourage you to have a good discussion with your physician about these.
And what are some of the things that would be cause for concern? I guess shortness of breath and, passing out after a practice, those kind of things?
Oh, absolutely, yeah. So shortness of breath in an athlete, particularly if that's unusual for them or they're not able to keep up with everybody else, and also passing out. Passing out can be due to just being dehydrated, of course, probably much more commonly, but passing out by itself can also be a symptom of underlying cardiovascular disease. So don't just completely blow that off. That needs to be looked at and evaluated because that may be the first near-miss symptom of something much more serious.
Mm-hmm. Anything else that you want to leave our viewers with today, Dr. Osborne?
Let me tell you, I really appreciate you having me on today, spreading this message, because it is such a major killer, still is a major killer, but we have significant opportunities to lower that risk. And ultimately, I tell people the reason I do preventative cardiology is I'm hoping that people listen to what we have to say today, put this to work, and ultimately, my goal is the more I do this and you do this, that ultimately you can help put me out of business.
That is the goal. Thank you so much, Dr. Osborne, for your time today. Hopefully we saved a life in this process.
Absolutely. Thank you so very much.
And thank you for joining me for this episode of That Expert Show. Boy, such good information. Again, I'll be reviewing the show and going through, gathering the key points that Dr. Osborne made, making a tip sheet for you that you can print out, you can share with your friends and family, because I know we covered a lot of ground there and a lot of specifics. He used a word that I can't even repeat the word that he used because it's so long. It's some kind of SAT word, but I'll have to review the air check for that. Remember, you can always connect with us on our various social media accounts on Facebook, on Twitter and Instagram, either at Anna Canzano or That Expert Show. And if you're not watching live, you can always watch us after the fact as well. We post our show on YouTube, on That Expert Show's channel, and we also put our content back out to you as a podcast. So you can listen to us on Apple iTunes, Google Play, TuneIn, Stitcher, wherever you listen to your podcasts. Again, want to give a shout out to the good folks at Reflex Knee Clinic. They have changed our life. They have helped solve the knee pain problem for my husband and dramatically improved our way of life. He can be the full father that he wants to be and engaging and playing with our girls and doing the things that he loves to do and being active with me as well. So if you've got knee pain, talk to the folks at the Reflex Knee Pain Clinic. All right, that's it for this episode of That Expert Show. Thanks for joining us. Hope you'll be with us next time on That Expert Show, where you help run the show.